Welcome, future nurses. Containing our daily 3 videos challenge, we are here with another vital area of cardiovascular nursing, conduction disorders. The heart's electrical system is what keeps it beating in a regular, coordinated rhythm. And when that system is disrupted, clients may experience anything from mild palpitations to life-threatening arrhythmias. Conduction disorders such as atrioventricular blocks, bundle branch blocks, and sick sinus syndrome can compromise cardiac output and place clients at risk for heart failure, at serious risk for complications like syncope, heart failure, or even sudden cardiac arrest. In this session, we will explore the nursing responsibilities in assessing and managing conduction disorders, including recognizing abnormal rhythms on an electrocardiogram, identifying clinical symptoms, and implementing both emergency and long-term interventions. We will also cover the nurse's role in caring for clients with pacemakers, monitoring for complications, providing medication education, and supporting lifestyle modifications to prevent worsening of disease. Hold on a second before we dive into the next NCLEX topic. I need to share something urgent with you. If you are serious about passing the NCLEX on your very next attempt, you cannot afford to miss the ultimate NCLEX crash course. More than 100,000 students have already cleared their exam with it. And you can too. Why is this course different? Because it gives you everything in one place. Live interactive classes, recorded lectures you can rewatch anytime, 5,000 practice-style questions, 30 practice tests, ebooks and PDF revision notes, a student planner, and detailed NGN question explanations. This is your shortcut to success. Don't wait. Scan the QR code or click the link in the description now. You will instantly unlock free study content including NCLEX quizzes, PDF notes, and practice tests, plus access to our Telegram and WhatsApp groups with even more support. Now, let us take a step into a clinical scenario that focuses on cardiac rhythm monitoring and patient teaching. A 54-year-old client is admitted after experiencing several unexplained syncopal episodes at home. To evaluate possible arrhythmias, the physician prescribes a 24-hour ambulatory electrocardiography using a Holter monitor. Before discharge, the nurse provides important instructions. The question asks, which nursing instruction will provide the most clinically useful data for accurate interpretation of the Holter monitor results? Here are the options to consider. Option A states, record the times and types of physical activities you perform during the 24 hours. Option B suggests, check and write down your radial pulse every hour during the day. Option C advises, avoid exercise or stressful activities while the monitor is attached. And option D recommends, keep your legs elevated while sitting to improve blood flow. The correct answer here is option A, record the times and types of physical activities you perform during the 24 hours. This is the most clinically valuable instruction because Holter monitoring is only meaningful when rhythm disturbances are correlated with the client's real-time activities and symptoms. The Holter monitor records the heart's electrical activity continuously during daily living, but without an activity diary, including walking, climbing stairs, meals, medication intake, emotional stress, or symptoms such as dizziness or chest pain, the physician cannot determine whether an arrhythmia is exercise-induced, spontaneous, or activity-related. For example, if syncope happens during stair climbing, the physician can match that exact ECG tracing to detect ventricular tachycardia, atrioventricular block, or pauses. That is why documenting both timing and activities is critical. On the other hand, option B, which asks the client to record the radial pulse every hour, is unnecessary and provides little benefit. The Holter monitor already captures continuous rhythm and rate changes with much greater accuracy than manual pulse checks. Moreover, hourly recordings would miss short arrhythmias such as paroxysmal atrial fibrillation or ventricular tachycardia that may last only seconds. Next, option C, which instructs the client to avoid exercise or stressful activities, is misleading. The purpose of Holter monitoring is to capture arrhythmias in the context of normal activity. If the client avoids exertion, exercise-induced arrhythmias or ischemic changes may never occur, leading to false negative results. Normal routines, including mild to moderate activity, should be encouraged. Finally, option D, which advises keeping the legs elevated while sitting, may help conditions such as venous insufficiency or edema, but has no role in Holter monitoring. Leg position does not alter rhythm detection or provide useful correlation for arrhythmia interpretation, making this option irrelevant. And here is your high-yield clinical pearl to tie it all together. Holter monitoring is only as good as the diary that accompanies it. The ECG shows the heart's electrical story, but only the activity log explains the plot. Without correlation, the physician is left with electricity without context. Now shifting into a cardiology scenario, imagine a 58-year-old client who has just been discharged with a prescription for a 24-hour ambulatory electrocardiogram. Using a Holter monitor to evaluate intermittent palpitations and unexplained dizziness, the nurse must provide clear teaching about what the client should or should not do while wearing the monitor to ensure accurate results. The question asks, to prevent electrical interference with accurate recording, which client action should the nurse instruct to strictly avoid? Here are the options. Option A suggests standing close to a microwave oven when heating food. Option B mentions driving under high-voltage overhead power lines during travel. Option C lists shaving with an electric razor before work. And Option D recommends talking on a cellular telephone for extended periods. The correct answer is Option C, shaving with an electric razor. This is because Holter monitors are extremely sensitive to electrical signals, and devices such as electric razors or electric toothbrushes can cause artifact, false tracings that mimic dangerous arrhythmias. This artifact may blur the heart rhythm record, conceal real problems, or even cause misdiagnosis, which is why manual razors are the safe choice. By contrast, standing near a microwave oven is not an issue since modern microwaves are shielded and do not affect Holter tracings. Driving under power lines is also safe because the electromagnetic fields at ground level are far too weak to disturb the recording. And finally, while cell phones transmit radio frequency waves, modern Holter monitors are shielded and not affected by them. In fact, using a phone is acceptable as long as the client logs the activity in the diary. Here is the clinical insight. Nurses should teach clients to keep a diary of all symptoms, activities, and medications so the physician can match those with the Holter tracings for an accurate diagnosis. A high-yield NCLEX tip to remember is that if the question asks about interference with Holter monitoring, always think of vibrating or motor-driven electrical devices like razors and toothbrushes. And here's a Stancoast pearl to lock this in your memory. A Holter monitor works like a 24-hour heart camera, but just like a photo can be blurred by shaky hands, the Holter can be blurred by electrical noise. The biggest culprit? Electric razors. That is why clients should always stick to manual razors to keep their heart picture crystal clear. Hey, future nurses! Before we jump into the next NCLEX topic, I want to pause and give you something that might completely change your prep strategy. Imagine walking into the exam room with total confidence, knowing you have the ultimate NCLEX crash course backing you up. This isn't theory. Over 100,000 nursing students have already passed with it. So, what's inside? Interactive live classes, binge-worthy recorded lectures, over 5,000 practice questions, 30 full-length tests, ebooks and notes for last-minute revision, a ready-to-use student planner, and NGN-style questions explained in detail. This is not just another review course, it's the complete package. Scan the QR code or tap the link in the description right now to join. As a bonus, you'll get free resources like PDF notes, quizzes, and practice tests, plus access to our study communities on Telegram and WhatsApp. Let us now dive into another NCLEX-style practice question that focuses on cardiac rhythm management and client education. A 64-year-old client is admitted with dizziness, palpitations, and shortness of breath. Continuous monitoring shows atrial fibrillation with a rapid ventricular response, and the physician schedules elective synchronized cardioversion. Before the procedure, the nurse provides teaching, and the question asks, which client statement indicates correct understanding of the purpose of cardioversion? Here are the options. The first option states, it delivers a controlled electrical shock to restore a normal heart rhythm. The second option says, it involves threading a catheter into the heart chambers to check blood flow. The third option explains, it is a nuclear test that scans the heart with a radioisotope injection. And the fourth option describes, it measures how well blood is circulating to different areas of the heart muscle. The correct answer is option 1. It delivers a controlled electrical shock to restore a normal heart rhythm. This is because cardioversion is a synchronized therapeutic procedure in which an electrical shock is delivered at a specific point in the cardiac cycle to restore sinus rhythm in atrial fibrillation, atrial flutter, or supraventricular tachycardia. Unlike defibrillation, which is used during cardiac arrest in ventricular fibrillation or pulseless ventricular tachycardia. Cardioversion is carefully timed with the R wave of the QRS complex to avoid shocking during the T wave, which could trigger dangerous ventricular fibrillation. Sedation is often given. The client is kept NPO beforehand. An anticoagulation must be addressed if atrial fibrillation has been present for more than 48 hours to prevent thromboembolism. On the other hand, option 2 is incorrect because threading a catheter into the heart chambers refers to cardiac catheterization, which evaluates coronary artery disease and intracardiac pressures, not rhythm correction. Option 3 is also incorrect because a nuclear perfusion scan with a radioisotope is a diagnostic test to assess myocardial perfusion or ischemia, not a rhythm treatment. Finally, option 4 is inaccurate because evaluating blood flow to the myocardium is done by echocardiography, CT angiography, or nuclear imaging, not by cardioversion. From a nursing perspective, preparation is essential. The nurse must ensure the synchronizer switch is on, defibrillator pads are properly placed, IV access is secured, and oxygen is ready. If atrial fibrillation has persisted beyond 48 hours, anticoagulation is mandatory for several weeks before elective cardioversion, or a transesophageal echocardiogram may be ordered to exclude atrial clots. After the procedure, careful monitoring for rhythm stability, oxygen saturation, blood pressure, embolic signs, and skin burns at electrode sites is vital. Stancoast. Pearl. Think of cardioversion as pressing the reset button on the heart's rhythm. It is not a diagnostic test, not a catheter procedure, and not about blood flow. It is a carefully timed electrical therapy to restore normal sinus rhythms safely and effectively. Let us now move on to another important NCLEX-style practice question that emphasizes cardiac safety and pre-procedure nursing care. A 67-year-old client with persistent atrial fibrillation is scheduled for elective synchronized cardioversion tomorrow morning. The nurse carefully reviews the medication administration record and must determine which prescribed medication should be withheld before the procedure to reduce the risk of adverse cardiac complications. Here are the options. Option 1 lists diazepam, also known as Valium. Option 2 presents digoxin, also known as Lanoxin. Option 3 offers heparin. And option 4 includes warfarin, also called Coumadin. The correct answer is option 2, digoxin. Digoxin is a cardiac glycoside that slows atrioventricular conduction and enhances vagal tone, which helps in controlling ventricular rate during atrial fibrillation. However, when cardioversion is performed while digoxin is active in the bloodstream, it predisposes the myocardium to dangerous arrhythmias such as ventricular tachycardia or ventricular fibrillation. This happens because digoxin increases myocardial irritability, and its effect becomes exaggerated under the electrical shock of cardioversion. That is why best practice guidelines strongly recommend withholding digoxin for at least 24 to 72 hours before elective cardioversion, especially if electrolyte imbalances like low potassium or magnesium are present, as these further magnify the risk of toxicity and arrhythmias. Now let us clarify why the other options are incorrect. Diazepam, in option 1, is a benzodiazepine sedative that is actually useful before cardioversion because it provides conscious sedation, reduces anxiety, and ensures client cooperation. There is no need to withhold it. Heparin, in option 3, is an anticoagulant that is vital for preventing thromboembolic complications. Clients in atrial fibrillation longer than 48 hours are at risk of developing atrial thrombi, and if cardioversion dislodges these clots, stroke or systemic embolism can occur. Therefore, withholding heparin would increase risk rather than protect the client. Similarly, warfarin in option 4 is also an essential anticoagulant. Clinical guidelines recommend continuous warfarin therapy for at least 3 to 4 weeks before and 4 weeks after cardioversion to minimize embolic events. It should not be withheld unless there is a contraindication such as active bleeding or a very high INR. To bring this together with high-yield learning points, anticoagulants like heparin and warfarin must be continued before and after cardioversion because they prevent clot dislodgement. Digoxin, however, must always be held for 24 to 72 hours before the procedure because it increases the risk of lethal arrhythmias during the shock. Additionally, clients should be kept nothing by mouth prior to cardioversion. sedated appropriately, monitored with continuous ECG and oxygen, and emergency resuscitation equipment must be ready at the bedside. It is also important to remember the distinction between cardioversion and defibrillation. Cardioversion is synchronized with the R wave to avoid shocking during the T wave, which could itself induce ventricular fibrillation. Stancoast. Pearl. Before cardioversion, keep the anticoagulants to prevent clots, but always hold digoxin, because under the shock of cardioversion, digoxin can turn the rhythm into a dangerous arrhythmia. Now let us take on another high-priority NCLEX-style question that focuses on evaluating the effectiveness of a cardiac procedure. A 67-year-old client with persistent atrial fibrillation undergoes elective synchronized cardioversion under moderate sedation with midazolam. The nurse is closely monitoring post-procedure findings to determine whether the intervention worked. The question is, which observation provides the strongest indication that cardioversion was successful? Here are the options to think about carefully. Option A states that the client regains consciousness immediately after the shock. Option B points out that a normal sinus rhythm with upright P waves precedes each QRS complex. Option C highlights that the apical heart rate is identical to the radial pulse rate. And option D mentions that the pulse pressure measures approximately 40 millimeters of mercury. The correct answer is option B, a normal sinus rhythm with upright P waves preceding each QRS complex. Let us break down the reasoning in detail. The therapeutic goal of synchronized cardioversion is to terminate atrial fibrillation, atrial flutter, or supraventricular tachycardia by delivering a timed electrical shock that resets the conduction system. Success is proven when the sinoatrial node regains its role as the primary pacemaker. On an electrocardiogram, this appears as consistent P waves before each QRS complex, a stable PR interval, and a ventricular rate between 60 and 100 beats per minute. This rhythm confirmation is the gold standard measure of success, far more reliable than hemodynamic values or mental status changes. Looking at the incorrect options, option A suggests immediate return of consciousness. While sedatives like midazolam or diazepam are short-acting, the speed of awakening reflects drug metabolism, not the outcome of cardioversion. A patient can wake up quickly, yet remain in atrial fibrillation. Option C highlights equal apical and radial rates, which does show that there is no pulse deficit, something common in atrial fibrillation. However, this only signals improved cardiac output and does not guarantee sinus rhythm restoration, since controlled atrial fibrillation can also give matching apical and radial rates. Option D points to a pulse pressure of about 40 millimeters of mercury. Although this is within the normal range and does show good stroke volume, it is not a rhythm marker. Blood pressure values alone cannot confirm cardioversion success, which is why the electrocardiogram is essential. To add a clinical pearl, it is important to distinguish cardioversion from defibrillation. Cardioversion is synchronized with the R wave, preventing the shock from falling on the T wave, which could trigger dangerous ventricular fibrillation. Defibrillation, by contrast, is unsynchronized and used in emergencies like pulseless ventricular tachycardia or ventricular fibrillation. Another key detail is that digoxin increases the risk of post-cardioversion arrhythmias, so it is usually withheld 24 to 48 hours before the procedure. Stancoast, Pearl. After cardioversion, do not be distracted by vital signs alone. Blood pressure and pulses may improve, but the only true proof of success is an ECG tracing that shows sinus rhythm with P waves leading every beat. Before we move on to the next NCLEX topic, let me share something that could be the game changer in your journey. If you are determined to pass the NCLEX on your very next attempt, the ultimate NCLEX crash course is exactly what you need. This program has already helped more than 100,000 nursing students achieve success. And now it's your turn. Here is what makes it powerful. Daily interactive live classes, easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks and PDF notes for quick revision, a ready-to-use student planner, and detailed NGN question breakdowns in comprehensive lectures. It is not just a course, it's your all-in-one NCLEX toolkit. Simply scan the QR code now or click the link in the description to enroll instantly. You'll unlock free content like PDF notes, practice tests, and NCLEX quizzes, plus access to our Telegram and WhatsApp groups filled with even more free resources to keep you ahead. Let us now dive into another NCLEX-style practice question that requires you to connect anatomy with clinical nursing care. A nurse is assessing a client who had a permanent pacemaker implanted just 3 weeks ago. At this stage, careful observation of the surgical site is vital to identify early complications such as infection, hematoma formation, or lead displacement. The question is, which anatomical location should the nurse inspect when assessing the permanent pacemaker battery pocket? Here are the 4 options to think about. Option 1 suggests beneath the left nipple. Option 2 points to an area near the brachial artery. Option 3 highlights the mid-sternal area. And Option 4 identifies the site just below the right clavicle. The correct answer is Option 4, below the right clavicle. This is the standard placement for permanent pacemaker generators, where they are implanted in a subcutaneous pocket beneath the clavicle, usually on either side. This location is ideal because it provides safe and direct access to the subclavian vein, which allows the pacemaker leads to be threaded into the right atrium and right ventricle. It also minimizes the chance of kinking or dislodging the leads and is cosmetically acceptable for most clients. When inspecting the site, the nurse must look for redness, swelling, drainage, warmth, or tenderness, all of which could indicate infection or hematoma. Gentle palpation may be done cautiously, but applying unnecessary pressure should be avoided as it can irritate the generator pocket or damage the pacing leads. Now let us consider why the other options are incorrect. Starting with Option 1, beneath the left nipple is far too low for pacemaker placement. This site does not provide good venous access and increases the risk of complications, discomfort, and poor healing. Moving on to Option 2, near the brachial artery, is also not correct. Pacemaker leads are always introduced through venous access, such as the subclavian or cephalic vein, not through an artery. Using the brachial artery would expose the client to risks like vascular injury, ischemia, and hematoma. Finally, Option 3, the mid-sternal area, is not a proper site for permanent pacemaker placement either. This site has minimal subcutaneous tissue, is uncomfortable, and could interfere with chest compressions during cardiopulmonary resuscitation. The mid-sternal region is sometimes associated with temporary epicardial pacing wires placed after open-heart surgery, but not with permanent pacemakers. Here are some high-yield NCLEX insights to keep in mind. Nurses caring for clients with pacemakers must close capture is seen on an electrocardiogram. Teaching points are equally critical. Clients should avoid raising the arm on the affected side above shoulder level for 1 to 2 weeks to prevent lead displacement. Always carry a pacemaker identification card and wear medical alert jewelry. Strong magnetic fields such as MRI machines or industrial magnets must be avoided because they can interfere with device function. Follow-up appointments with the electrophysiology clinic are essential for checking battery life and ensuring proper device function. Stancoast. Pearl. Always remember, pacemakers live beneath the clavicle, not near the sternum, not beneath the nipple, and never by the artery. The clavicular pocket provides safety, stability, and protection, making it the nurse's #1 site for inspection to catch complications early before they escalate. Let us now move into another important NCLEX-style practice question that focuses on client safety and pacemaker education. A client with a history of sick sinus syndrome has recently undergone placement of a permanent artificial pacemaker. During the first week of discharge teaching, the nurse emphasizes the importance of recognizing early signs of pacemaker malfunction. The critical question is, which clinical finding should the nurse teach the client to report immediately as a possible indication of device failure? Here are the options to consider. Option 1 suggests a tingling sensation in the chest wall. Option 2 describes dizziness, lightheadedness, or syncope during physical activity. Option 3 highlights radiating pain from the chest to the left arm. And Option 4 points to localized tenderness and swelling at the insertion site. The correct answer is Option 2, dizziness, lightheadedness, or syncope during physical activity. Here is the rationale. Pacemaker malfunction can involve 3 major problems: failure to pace, where the pacemaker does not initiate an impulse; failure to capture, where the impulse is generated but the myocardium does not respond; or failure to sense, where the pacemaker does not recognize intrinsic cardiac activity. All of these can lead to bradyarrhythmias, pauses in rhythm, or decreased cardiac output. When cardiac output drops, the most noticeable clinical symptoms are dizziness, fainting, and lightheadedness, particularly during exertion when the body requires more blood flow. These are red flag warning signs of inadequate cerebral perfusion and must be reported urgently because they may signal life-threatening arrhythmias. Clients should be made aware that even brief syncopal episodes can lead to falls, trauma, or sudden cardiac events, making these symptoms the hallmark indicators of pacemaker malfunction. On the other hand, tingling in the chest wall, as described in option 1, is generally unrelated to pacemaker function. Tingling is more often linked to nerve irritation, mild muscle spasms, or anxiety around the surgical site, and while it may be uncomfortable, it does not represent pacing failure. Moving on, option 3 describes radiating pain from the chest to the left arm. This classic symptom points to myocardial ischemia or infarction, not pacemaker failure. While clients with pacemakers can still develop coronary artery disease, the presence of chest pain radiating to the arm should be treated as an emergency for ischemic heart disease, but not mistaken for pacemaker malfunction. Lastly, option 4 involves localized tenderness and swelling at the insertion site. These changes suggest infection or hematoma formation at the pacemaker pocket rather than malfunction of the device itself. Though concerning, they represent a surgical site complication, not a systemic pacing failure. From a clinical perspective, the high-yield takeaway is that true pacemaker malfunction reveals itself through systemic hemodynamic compromise. Symptoms such as bradycardia, dizziness, palpitations, hypotension, and syncope must be prioritized and reported promptly. Nurses should teach clients to differentiate between general discomfort or local issues and the life-threatening systemic signs of device malfunction. It is also important for clients to carry their pacemaker identification card at all times and notify their healthcare provider immediately if dizziness or fainting occurs. Stancoast. Pearl. When it comes to pacemakers, the body's first alarm system is the brain. Dizziness or fainting reflects a drop in cardiac output and is the most urgent sign of pacemaker failure, making it the #1 red flag symptom every client must recognize.